Anyway, it's a pleasure to see everyone. I'm going to get started now. I'm just clicking a few more people that I've admitted. I'm very pleasantly surprised that we have close to 100 people, over 180 people registered. We have close to 100 people already here. And what I'm going to do is I've assembled a PowerPoint presentation. It's taken from 2 lectures I've given in the past 6 months on hair transplant techniques. One of the presentations was given at the most recent meeting held last month in probably one of the last scientific meetings that were held in the facial plastic surgery community. It was Miami Cosmetic Surgery. It's easy to get to. I was able to lecture on the present and the future of hair transplant and the treatment of hair loss. And the other meeting was from Bangkok, Thailand, the International Society of Hair Restoration Surgery meeting, where I actually gave a lecture on hairline design. So anyway, with no further ado, I'm going to go ahead and, good, I'm just admitting more people. So anyway, I'm gonna go ahead and start my lecture. I hope that you all can see everything. And just to let you know, if at any point you want to ask a question, just click the chat button and you can go ahead and, I'm just gonna move this box away. You can click the chat button and then I'll be able to answer questions. I actually was emailed some questions as well. And so I'll be answering them as well. It's a little odd talking to a whole group of people and being able to hear no one. So I'm sorry if I sounds a little awkward. I'm used to, having some feedback from when I talk. I'm actually sometimes as good a listener as I am a speaker. So I do apologize if I seem a little hesitant at times to proceed, but I know you're all out there and here to listen. But anyway, let me go ahead and talk about the present and future of hair restoration surgery. As I said, this was presented from a meeting held in Miami Beach. Can I ask you one question? Are you able to see the full screen, the PowerPoint presentation? Great. And you're not seeing the waiting room list? Okay, good. This way I can keep on admitting them. And cool. Great. All right. So with no further ado, let's get going. And I have nothing to disclose. We do this with all of our scientific meetings. Doing hair restoration surgery since 1993. This was me, probably in 1995, my first glamour shot used for my original brochure. Bill Clinton was president. Backstreet Boys were hot. Not for me, but they were hot for at least on the air. And this was the days of plug transplants. Things have come a long way. Today, we're able to achieve really natural appearing hairlines in other parts of the scalp. Really able to avoid linear scars with the follicular unit extraction technique. We're able to use beard and body hairs with fairly consistent results now, particularly beard hairs. Nice thing about FUE is it's a quite easy recovery. It's low risk. We also have improved techniques for scar reconstruction. I'm going to touch a little bit. I'm going to integrate some micropigmentation information. And I'm going to conclude. I'm going to talk about cell therapies. So follicular unit grafting, or also called strip techniques, that was the technique used from essentially 93 to 2005, was the gold standard. I would say around 2005 is when we started exploring the technique of follicular unit excision or follicular unit extraction, also called FUE. But FUG or FUT is the strip approach, and it was a good technique, but it did leave a fine line scar. And you can see, particularly in all these cases, even though the patient's able to easily conceal these scars that are usually made in the back of the head, and most scars were 2 to 3 millimeters, there were these outliers where the scar would widen. There was also the issue that that patient was unable to cut their hair really short. no shorter than a 2 or 3 most commonly, because the scar will potentially show. Well, the good news is follicular unit extraction. Thanks everyone, someone sent a chat. So, but the good news is follicular unit extraction has, well, by the way we treat these, today we treat these scars, and you can see on your left of your screen is a linear scar. And on the right was, that was a patient of mine that was done around 15 years earlier. And he came back and we did some micropigmentation, scalp micropigmentation, which is a nice way for going ahead and helping to conceal the scar. It's a single procedure or sometimes 2 procedures for doing fine line little tattoos. But here is the technique of FUE. It's a much less invasive procedure. Each graft is removed one at a time. You can see in this case, we're using a drill system, and the hairs get removed. And we're basically taking these little clumps of hairs, and we're creating, or we're obtaining these perfectly designed or perfectly created by God or by our scalp, are perfect grafts, which typically contain 1, 2, 3, or 4 hairs. Most commonly, they contain 2 and 3 hairs. And this is what a follicular unit graft looks like. This is the cornerstone, the foundation for doing a hair transplant, where we use, and I'll explain how we use single hairs for the hairline, 2 hairs for a little further back, and 3 hair grafts for achieving greater density. So we're able to extract these grafts one at a time. You can see the before, right after the procedure, 1 day after, and then long term. And you can see how patients are even able to shave their head in the great majority of cases, particularly if procedures were done, with less than 1,800 to 2,000 grafts. Many patients, and I basically advise patients that in around 20% of patients, after a single FUE procedure, around 1,800 to 2,200 grafts, around 20% will be unable to shave their head without fine dots showing unless they get micropigmentation. Typically 70 to 80% of patients after that single procedure have no issues at all, able to cut their hair virtually as close as short as they'd like to. And then with a second procedure, because many times patients, or sometimes patients will come back for more work, with that second procedure, there's an increased risk of having a greater amount of little patchiness that shows. Once again, it's a trade-off, like everything else, whether you're doing a facelift and you're leaving someone with a fine line scar, or whether you're doing a hair transplant, you are inevitably, plastic surgery requires leaving some type of scar. We minimize it, and that's the advantage of FUE, is that there's no linear scar. So this is one of the key elements, is knowing that the male pattern hair loss is a progressive process. And we like to remember that hair loss will be progressive. So a patient presents to us, for example, with early frontal temporal recessions, we have to anticipate if they're in their 20s or 30s, that more than likely they will progress to a stage 4 or 5. There are medical therapies. Most effective are Propecia and laser in our practice. Other therapies include Rogaine, PRP, vitamins, particularly that are helpful in women. But these medical therapies can slow down the progression of hair loss. I'm just admitting a couple of people, I apologize. So we have to keep in mind when designing hairlines and recommending procedures on the progressive nature of hair loss. This is an example of a woman. FUE can be used for women, although many women will go ahead, because if they're never going to shave their head, we will use FUT or do a strip, because we can harvest the hairs from the most dense part of the scalp and be able to fill in a case like this. Now, there's an alternative to doing transplants in certain women, and that is doing micropigmentation. We're essentially darkening the scalp with these micropigmented dots. I showed you a prior case done for a donor site scar, but it can be used for creating a thicker look in a woman, and in this case, a man, where we did half his scalp. The left side was done with micropigmentation, and the right side he hadn't had anything done. So micropigmentation, which lasts for around 5 years, can be a nice, effective way for providing a fuller look. I will add that I'm having my micropigmentation expert do a webinar next week. He'll be talking and sharing his experiences on SMP, because we do, on the average, 3 or 4 SMP cases every week. So FUE, before and after, patient's able to wear his hair as short as he wants. Before and after, around 1,700 grafts, you see the nice improvement that we're able to achieve working within the existing hairline. The healing is quite quick. The day of the procedure, I apologize, this patient took his photos at home. This was 2 days after. His hairs are already growing in. Typically, we shave the back of the head. And we do also do other ways of preparing the scalp, and I'll show you that later. But here you can see that this is the result at 7 days after. So by 6-7 days after, if a patient undergoes a shave approach for harvesting of the hairs in the back and sides, they should be presentable. So follicular unit excision involves the extraction of each follicular unit one at a time. We use, in our practice, we use the newest systems, which is the FUE, designed by a colleague of many of ours in Belgium, and the Trivellini, designed from a colleague from Paraguay. And we use small punches, typically 0.8 to 0.9 millimeters in size. There are also handheld drills. There are handheld punches, rather, excuse me. We use the handheld drill, which is has different ways of working. We like an oscillating system most commonly, as opposed to a rotary system. More of the commercially available systems, what we call the NeoGraft, SmartGraft, and even the Artist, which is a robotic system, they tend to use, or they only use, my understanding is sharp punches. Sharp punch technology has a higher rate of transection. We've proven that in the majority of cases, that the transection rate is lower with using these more modern systems. Transection is bad because transection means that the follicle may not be viable, so you may not get as much hairs grown. So we like to use the FUE, the Trivellini system. Most of my top colleagues, and some of them are shaking their heads, these are the systems we use. Most of the top doctors do not use the Artist nor the SmartGraft and NeoGraft. Every doctor is different. Another advantage of the handheld drills is that, well, let me show you. This is the Artist, and you can hear that as opposed to what we use with the handheld drill. And you see it's just a gentle approach. This is an all or nothing approach with the Artist, and this is with our punches. So we're able to do a more gentle extraction, plus with a good surgeon at the, and this actually that's my wife Grana, a good surgeon at the tail end. We're able to create really nice grafts. And these are some typical before and afters. Before and after, 2,100 grafts. Another example on a 24-year-old, around 1,300 grafts done to conservatively restore his hairline in an area that even as he gets older, this will still look natural. It was done conservatively. I will also combine medical therapy, as I talked about, Propecia, laser, Rogaine, and or PRP. We do PRP, or platelet-rich plasma, with all of our transplants. We find that it reduces the risk of shock loss. The building up, in this case, not only of the hairline, but also of the temples, before and after a procedure. It also can be effective in, this is the most senior of all the patients. Actually, I did a gentleman, 83 years old, just in February, but this gentleman had 79 years old. We restored a frontal forelock to create a more youthful look. And this is our technique of planting the grafts. I'm going to show in a couple minutes of video how I design Hairline, but it's a 4-person system. You've got 2 people going ahead and actually loading the hairs onto what we call implanters, and then the other 2 assistants are actually placing the grafts into recipient sites that I have created. I do believe that all recipient sites should be done by the surgeon. It's the way I do it, and then we place the grafts. After we fill these first 600 or 700 recipient sites, for example, on a case of 2,000 grafts, I'll then come back. I'll make 500 to 1,000 recipient sites, get those filled, and then I'll come back and make more recipient sites. FUE can also be a nice way for doing reparative procedures. These are the old plugs, and you can see by just doing additional grafting, we're able to go ahead and fill in a lot more and create a more natural look. Another technique, another way rather, an application that FUE can be used, a guy that had prior transplants, these were done unesthetically. There are 2, 3, and 4 hair grafts. They're sticking up 2 perpendicular. They're in a straight line. What I actually did was remove those. We moved around 800 of them, and this is healed up to a much more natural look. These hairs that were removed were replanted further back. At this point, the patient came back. We did a little bit more removals, and we also went ahead and did additional grafting. I'm sorry, this was 1,400 grafts. So anyway, we talk about FUE, how we prepare the scalp. Most standard is the shave FUE, where basically the head is shaved to the back and sides, and this is the donor area. Typically, in a patient who is at risk for developing crown loss, will go up to superiorly or up to this point, and this is all the donor area. So we'll only go the area in the very back of the head, which is deemed to be permanent based on experience, particularly experienced surgeons like myself. Sometimes we'll offer a partial shave where we'll just shave from the ears and below. So we're able to give the patient sort of a fade look. And this is used, probably the most common technique we use, because we're able to get around 800 to probably 12 to 1400 grafts from the shaved area. And then to get the additional grafts with the middle one, the partial shave, we can take those out individually without needing to shave. So therefore the patient typically looks pretty good at 3-4 days. And finally, we do offer a no shave FUE, where there's no shaving at all of any of the areas of the scalp, just each individual follicular unit. As we transection, we remove it rather, by the FUE drill, we actually snip the hair, remove the graft. So this one allows the patients to literally be presentable the very next day, assuming they've got some hair on the top of the head to conceal what we're doing. And we do not do any trimming typically of the recipient area. We work around the hairs for 2 reasons. Number one, aesthetically, it allows patients to return to be more presentable sooner. But reason number two is that I can actually visualize as I'm making the recipient sites how the hairs, the existing hairs or the native hairs lay as I'm working and adding in additional hairs. Let me show you this video. And this is a 10-minute video. I apologize if none of you want to watch it. Start sending me some chats and tell me take off the video. But I do think it's a really nice video for explaining how I design hairlines, create hairlines. So I'm going to start it now.
Hey, did you? Hi, puppy. Mwah. How's your day? I'm almost done. Then again, come play with you, okay? Mwah.
Michael, we can hear you, man.
Sorry.
Hello, Dr. Epstein, we can't hear you somehow, the video. No audio, okay.
Yeah, Dr. Epstein, it seems like your video audio is not working.
I sincerely apologize. I'm not sure what I'm doing. I played the video. Anyway, I'm just going to go ahead and talk about how I go ahead and do hairline design. And I do apologize. This video is available on my YouTube channel. So once again, I do apologize. Basically, when I design a hairline, actually, this will give me a chance to talk in person. Basically, there's two elements to hairline design. The first is the actual shape of the hairline, where it's placed. The second is how the hairline is actually created, like on a micro level. In terms of positioning a male hairline, there's a couple of landmarks that we use. The first landmark is where the vertical forehead meets up with the horizontal scalp. And that's usually a point around 8 centimeters to 9 centimeters above the nose. And that's usually a rough starting point of where a good hairline should be. Now, many times we'll design a hairline a little bit higher up. The advantage of going higher up is that it creates a more conservative look, particularly in patients who you're trying to make sure that you have plenty of donor hairs available for the future. By going up slightly higher, you'll make sure that you can go further back, because if you have a limited supply of total donor supply, the higher up you go, potentially the further back you can go on patients who either have or are at risk for developing a more advanced degree of hair loss. In terms of how we design the sides, how it recedes, what you don't want is a hairline that goes straight across for men, or a hairline that wraps around. What you want to see, particularly when the patient is on what's called the Frankfurt horizontal, they're turned horizontal, is that it actually goes up a little bit. So this is the lowest point where the widow's peak is, and it wraps up and goes slightly higher. And then it meets up with the temple sides. It's always advantageous when a patient, if they have a more advanced degree of hair loss, but their sides are somewhat high, you can actually have these sides also continue back a little bit higher to create a more receded look. And then, so therefore you're preserving the hairs as much as possible. And by doing that on a more conservative approach, you're then leaving more hairs available for use in the future.
No, that's okay.
What we like to do is, in addition to creating a nice relatively solid hairline, to create the appearance of a lower hairline without allocating a large number of grafts, there are two effective ways. One is to go ahead and create a widow's peak, which a lot of patients like, which makes the hairline look low without allocating a large number of grafts. The other way is doing feathering, sort of doing a lot of single hair grafts along the sides, and that will create what's called a feathering look. So you thicker here, and then you're really feathered on the sides. Some patients like a thicker hairline, and we can accommodate that as well. But that's as far as positioning the hairline, so wanting it receded and wanting it high enough. The second element we use for designing a hairline is how the actual hairs look natural. In other words, how do we make sure that it looks natural where the hairs are placed? There's two things we talk about. One is that you want a waviness to a hairline. So a hairline is not a straight bowl, it's actually slightly irregular, and it's irregularly irregular. The other things we do to create a natural looking hairline is to have zones of thicker and thinner. So basically what we do is I create these little clusters or these little triangles of these little bunches of 2 hair grafts, that I use the 2 hair grafts to create it, make it a little thicker. And then I do that all across the hairline, a little thicker, thinner, a little thicker, a little thinner. And then I take single hairs after I've filled in these 2 hair grafts that create the micro irregularity. Then I place single hair grafts, what are called the micrografts or single hair grafts, to create a softer look. So use of 1 and 2 hair grafts is used together to create natural appearing hairlines. We're not just using all single hair grafts just placed all on the frontal hairline, create a natural look. We're actually using a mixture of 2 hairs, then using ones in front to really break it up. So those are essentially the main elements of hairline design. And hang on a sec. I want to go ahead and let me show you this. I'm going to show you now. I'm going to continue on with my, I'll pass that video. And I want to share some other things related to FUE. So, resume slideshow. Okay. One of the risks of FUE is over-harvesting. We see this a lot with overzealous surgeons and or assistants who are not properly appreciating the concept that there is a finite supply of donor hairs. And in these cases where some doctors are doing 2,800, sometimes even more, 2,800 can be somewhat of a borderline, but doing 3,500, 4,000, even 5,000 grafts in a single procedure can leave a patient with a moth-eaten look due to the removal of these hairs, because once you take them out and put them here, they will continue to grow here, but they won't grow any further in the back of the head where they come from. So therefore, you can get this moth-eaten appearance, this patchy appearance, and this should obviously be avoided. This is the kind of look, this is a before and after, 2,800 grafts, but the patient can wear his hair as short as he wants, so he has very good donor density in the back of his head, but still he's got no signs of scarring. He's got plenty of donor hairs, certainly enough to come back and do a second procedure. In terms of doing hairline lowering, just another example, an Asian gentleman, hair tends to be coarser. It's a little more difficult to make look natural. You can see that I didn't just create a universal appearance of the hairline. He's got these little zones of it's a little thicker, a little thicker, a little thicker, a little thinner, and it's also got a little bit of a waviness. So I was able to lower this gentleman's hairline and make it look fuller with grafting. Another way to lower overly high hairlines, and I will be doing a webinar on this. Another one is called hairline lowering surgery. This gentleman was just 4 months after a hairline lowering surgery. We actually take his entire hairline and bring it down, and that's done. The results are instantaneous, and the result is you can create a lower hairline. Other examples, this is before and 1 week after hairline lowering surgery. You can see the hairline was lowered an inch. Another example of before and after, hairline was lowered just about an inch. And finally, another gentleman before and after. Most men are not good candidates for hairline lowering surgery because of a risk of future hair loss, but there is an indication, and as I said, I will be discussing that on a webinar. Well, other things we do eyebrow transplants. We're able to use these FUE grafts and create really nice natural looks before and after for both women and men. Also, we use FUE grafts for beard transplants. We also can even do armpit hair transplants, pubic hair transplants for scarring, and even arm and leg hair transplants. These are not the routine procedures we perform, well, particularly arm and chest and pubic, but we regularly perform eyebrows and beards, but these are all indications. This is all part of what we call body hair transplants, or BHT. Another role or another type of BHT is the use of body hair for placing into the scalp, particularly on patients that have run out of donor hairs, whether due to prior scarring or over harvesting, or whether because they just will not have enough donor hairs to cover all the areas of their scalp that have hair loss. So we can do these body hair grafts. So this is an example. We can take chest hairs. This is a joke. Can you remove the hair from my back and put on my head? And the reality is yes. So we can actually create fuller looks. Another example, using beard hairs before, after on the left and after on the right. We're able to use these beard hairs for creating fuller looks. This was actually a transgender patient prior to transitioning, was a male becoming a woman, and we were able to harvest most of his beard hairs over 3 procedures. So before we even did any scalp hair donors, we used his beard hairs just for creating a fuller look, knowing that she was going to need a lot more hair work to create a more natural looking hairline, a more feminine looking hairline. For that, we were going to use scalp hairs. Another example of a gentleman with a very hairy back, before and after. Body hair is not as reliable, particularly back and chest. It's not as reliable as using a scalp or beard hairs. Beard hair is the second most reliable. We still do these on a regular basis. Finally, let me talk a little bit about where I see cell therapy having a role in the hair restoration practice. We talk about regenerative cell therapies. This includes everything from PRP to stem cells and everything in between. We've been using basically 3 forms of cell therapies. One is PRP, and we're going to have a webinar on that. One is the use of autologous, which means coming from the patient's own fat. And finally, there are some commercially available products which we have not had a chance to start using, but there's some research being done with something called exosomes, which are at this point the FDA is setting out or being very cautious about letting them be used other than for experimental basis. So let's talk about these different cell therapies, fat, stem cells. We did a stem cell study. This was an example, before I do that, of fat being injected into the scalp. This is this patient's own fat. This is before and after, around 8 months later, and you can see the improvement in density. This is not a cure, but there's a sign that fat, someone's own fat, helps the hairs to grow thicker. We will be looking at future therapies using, developing therapies using adipocyte or fat cells, also regenerative cells, i.e. stem cells, which at this point, stem cells are not permitted by the FDA, at least the patient's own stem cells, because you're not allowed to manipulate either fat or you're not allowed to manipulate an individual's fat. I believe bone marrow can be used, but fat, which is the most common and easiest source of fat cells, of stem cells, cannot be used because it requires either chemical or mechanical manipulation, which is not permitted. I mentioned something about exosomes, and then there's hair cloning, which we are, there's a lot of research being done, the concept of being able to replicate unlimited amounts of hairs. In the case of what we're doing right now is a project called Hair Clone. There's a limited amount of doctors worldwide that have become partners in this program that started through a colleague of ours in Manchester, England, Bassam and Nilofer Farjo, who have developed this proprietary technology where we're actually starting to harvest individuals' healthy hair follicles, sending it to this bank, this cryobank in Manchester, England, where these cells will be frozen. Then once we develop the technology for replicating these healthy bulge cells that are these bulb cells that are used for that are responsible for strong hair growth, we then anticipate eventually being able to inject these replicated cells that we've multiplied thousands or even hundreds of thousands of them back into the scalp where there's thinning hair. And the concept is hair clone will be able to rejuvenate, not necessarily regenerate, but rejuvenate thinning hairs. Finally, stem cells at this point are overhyped based on their current efficacy. There's been no studies that have truly shown scientifically their merit, but we do feel that there is a tremendous opportunity for them. There is genuine autologous stem cells at this point are from fat are not FDA approved. Autologous fat, which we've been using, holds tremendous potential. We've been using it not just for the treatment of male and female pattern hair loss, the use of individuals' fat, but even for treating things like frontal fibrosing alopecia, lichen planopilaris, and other scarring alopecias, which right now there's not a lot of therapies. Actually, one of the therapies is Plaquenil, and some of the other products which are actually being used to treat COVID. So who knows if these drugs are even going to be available for the next 6 months. Bottled biologicals need to be studied to prove efficacy. And finally, hair clone is something we will be soon offering. I am a member of the International Society of Hair Restoration Surgeons. It's a wonderful organization of over 1,200 doctors worldwide. I think it's a good way if you're considering having a hair transplant. It's a good first step towards determining whether a doctor shows some commitment to specializing in hair restoration surgery. There's also the American Board of Hair Restoration Surgery. ABHRS is not a fully licensed board, but it's a well-accepted board because it shows clinical competency. A doctor needs to pass both a written and an oral exam to be an American Board of Hair Restoration Surgeon diplomat. So anyway, I'm going to stop sharing. I have you all muted, and I apologize, just that I'm trying, there's just over 100 of you, I believe, attending, but I'm so happy to start answering chat questions. Before I do that, I have a couple of questions that I received from patients over the last couple of days. The first one is, I recently had a hair transplant at another practice back in February, so just a month and a half ago, and experienced some rather significant shedding or loss of the native hairs in the recipient area afterwards. I've been a little bit concerned that the surgeon inadvertently transected some of my native hair follicles while he was creating the recipient area. My question is, damage to native hair is a common issue hair transplant surgery, and are there any techniques that should be used to avoid it? So first of all, this is called shock loss. It should occur in a relatively small percentage of patients. There's lots of ways to avoid it. First of all, is not operating or doing a transplant on a patient when he or she first presents to the doctor, and if they have signs of thinning or delicate hair. If a patient comes to the doctor's office saying, I want a hair transplant, I'm actively losing hair, in general, that patient should not undergo a hair transplant right away. These are the exact patients I will always recommend medical therapy: alopecia, laser, Rogaine, PRP. And the concept is, or the advantages of putting them on preventive therapies are several of them, numerous. One is you're strengthening their existing hair, so if and when they undergo a hair transplant, there'll be a much lower risk of having shock loss. Second, they may get some regrowth, not just a little bit of regrowth, but some moderate amount of regrowth. So give them 4 to 6 months of regrowth, maybe even longer, and maybe you'll minimize the number of grafts that are needed, or maybe even ideally, the doctor will be able to avoid the need for a hair transplant at this time. Third, in most cases, particularly patients under the age of 45 or 50, preventive therapy is an important component of the total treatment of hair loss, because if you don't go ahead and put them on preventive treatment and they've got the genetics to continue losing hair, they'll wind up, yes, you'll add more hair, but they'll continue losing more hair. So you're sort of, it's almost like a bucket. You're putting water in, it's got a hole in the bottom, and meanwhile, it's trickling out on the bottom. So we want to control the hair loss. Now, preventive therapy is not necessary on all my patients. Patient comes in, he's 48 years old, he's lost most of his hair on the top of his head. He's not really worried about the crown. He's looking, he wants a nice frontal forelock. Bingo, I would feel very comfortable proceeding, right with this procedure. So that's the concept of preventative therapy, particularly on young patients. Any patient under the age of 23, 24, 25, I will put them on preventive therapy a minimum of 6 to 12 months. This is young men, first of all, to make sure that they are comfortable, that they're not rushing into a decision, but also to help stabilize their hair loss. Other ways shock loss is prevented is obviously done by careful techniques by the surgeon. I wear significant magnifiers, which allow me to see between the existing hairs. I carefully make each recipient site with good visualization, keeping the surgical field nice and clean. And I carefully make every recipient site. We use very small blades for making the recipient sites, 0.5 to 0.7 millimeters. Typically, we use a 0.5 millimeter recipient site, which is half a millimeter for 1 and 2 hair grafts, 0.3 millimeters, 0.6 millimeters for 3 and 4 hair grafts, sometimes 0.7. Smaller blades, smaller recipient sites, less risk of damage to the existing hairs. Other ways to avoid shock loss, we do PRP at the time of the transplant. We find that does anecdotally, which means not by any scientific studies, but I found that it reduces the risk of shock loss. Women tend to be more at risk for shock loss than men. My incidence of shock loss, I can happy to say that probably less than 5% of my patients, I usually get maybe 2 or 3 every year, that have any degree of noticeable hair loss. I usually get 1 that's pretty significant, but we're talking about doing around 500 to 600 cases a year. Next question, and I'm going to go to the chat. Doc, how does a patient know for sure how many grafts they actually received? Also, can you explain the likelihood of transection? How do you know how many grafts you received? If you can't trust your surgeon to go ahead and do an accurate graft count, I think you're at the wrong doctor. You have to rely on the doctor, not necessarily technicians that are going to do all the extractions of the recipient sites, which is not, there's many questions about not just the ethics of that approach, where technicians or turnkey procedures, where doctors do the entire procedure, but there's also questions about how it's done properly and also the ethics of it. So we strongly advise that you find a surgeon that you can trust, so you know that you feel comfortable with the grafts that were transplanted with graft count. Also, can you explain the likelihood of transection? I think transection, we talked a little bit about it in terms of recipient areas. Transecting hair follicles will result in shock loss, which should be avoided. Transection in the donor area, it should typically be kept less than 5% of all hair should be transected with the newer techniques of FUE, with the small punches, the oscillating, the punches that have the, that are called the hybrid punches that aren't sharp. Those are all ways to reduce the risk of transection. So let me go down to questions now. I've got a lot of good questions. I'm gonna go right to, okay, finasteride versus dutasteride experience. Rarely do I prescribe dutasteride. Finasteride, which is also called Propecia, is really the gold standard for medical therapy for hair loss. Finasteride is given in 1 milligram. You can buy the generic 5 milligram pills and cut them into quarters. That seems to be the closest equivalent to 1 milligram, the brand name, as opposed to buying 1 milligram generic, which may not have the full 1 milligram. There's very little reason in my experience to put a patient on dutasteride. Dutasteride is also called Avodart, because the problem with dutasteride is that it can, dutasteride has a higher incidence of complications, and no one's shown that it has any greater efficacy. Hang on a second. Okay, next one. Okay, some doctors claim that with FUE, some follicular material can remain, which can then result in regeneration of the follicle. What is your experience with this? I think it's pretty clear that transection is bad when you're doing it in the area of the donor area, because you're not just going to potentially damage the hairs and cause the lack of their regrowth in the donor area, which normally doesn't happen, but you're not getting the advantage of having the hairs growing in the scalp. So I think we almost universally feel that it's a waste of hairs, or it's a discarding of hairs. There are some studies that doctors have tried showing that you can partially transect hairs and they may grow back both in the donor and the recipient area, but the data on that has not been as strong as I would feel comfortable recommending anything other than avoiding transection. Next question. I know I saw coming down. Okay, Dr. Epstein, my testosterone is at a very low normal range. I'm currently on finasteride and low-level light therapy, but if I decide to do T replacement or testosterone replacement, am I at risk for losing my hair? Great question. There's a lot of guys that have low T that are taking testosterone supplementation. My experience is that the addition of testosterone can increase the rate or the risk of hair loss. Some patients don't have this. By being on finasteride, theoretically, you're blocking that result of the elevated testosterone taken exogenously by pellets or by gels or by shots. But in general, my advice to patients that when they're on testosterone is be prepared for experiencing some degree of hair loss. And that's a problem. And unfortunately, there's not much we can do once those hairs have fallen out. Dr. Epstein, what's your opinion on bell versus rounded hairline? Hairline design is the artistic component of a hair procedure. So it's so critical that it be done artistically. I go over at the beginning of every procedure with my patients. I present them different options. I draw that in. I do it free-handed. I don't use templates. This is true whether I'm doing hairlines, but also for eyebrows and other areas. I think this is where the artistry of a hair transplant procedure comes in. I think hair restoration surgery is a wonderful aesthetic surgery. I think it's becoming more and more accepted as a true plastic surgery, and hairline design is really how the surgeon will be judged, not just in terms of the design, but how the hairline is actually created in terms of the naturalness, the angulation, how far the hairs are growing forward, how they're distributed, how you're going from a lower to a greater density, and things like that. Next question. Can you get more grafts with FUT or FUE? Great question. And also, what's the rate of regrowth? Recent study by colleagues of mine, David Josephidis and Ron Shapiro, showed, it was published in the Hair Transplant Forum, showed that the rate of regrowth with hairs that are harvested by good FUE surgeons with the proper technique is every bit as high as it is with FUT, which was the gold standard up until 2005 to 2008, maybe even for many doctors as recently as 2014, 2015. Some doctors are still performing FUT or strip surgeries. However, FUE, in my opinion, in most cases is the preferred procedure. So the rate of regrowth with FUE grafts appears to be just as good as it is with FUT. In fact, I'm almost going to go out on a limb and say because there's less handling of FUE grafts, they come out and then they get put in, that our rate of regrowth is actually as good, if not a bit better. Can you get more grafts total with FUT or FUE? Over the course of an individual's lifetime, if someone's going to get, well, generally an FUE total number of grafts without leaving a patchiness in the back of the head, in my experience, is somewhere between 4,500 and 6,500 grafts. So that is typically less than the total number of grafts that what can be obtained by an FUT, 1 or 2 or 3 FUT procedures where each time you're going back in and removing the old donor site scar. However, the trade-off is you're leaving a linear donor site scar, which unless a patient knows he's always going to leave his hair a bit longer, at least a 3 or a 4, I don't recommend FUT. Any younger patient under the age of 40 or 35, I won't do FUT at all, and I rarely do them for guys. I don't do them very often for guys over that, because listen, a guy's 30, he may never think that he would ever shave his head, but he gets to be 45, and suddenly he likes shaving his head. Next question. In some hair lowering procedure, initially the scalp looks very tight. Does the scalp relax afterwards? I'm actually going to be doing a webinar on hairline lowering surgery, but the answer is yes. We're actually pushing the hairline forward, and it's secured in that place, and the scalp will be tight for several weeks to several months, but then it does regain its normal laxity, but meanwhile it's held in place. When will you start doing PRP after a hair transplant? PRP we do at the same time as a transplant. It's included with our procedures. However, we also recommend it for patients that feel it is worthwhile to repeat it at around 3 months after the procedure. The PRP system we use it's not recommended to do every week or every 2 weeks. The system we use actually is done once, and then repeat it 2 to 3 months later, then every 3 months after that. So if a patient wants another PRP after the transplant, we'll start that typically as soon as 2 to 3 months after to potentially accelerate the regrowth of the hairs. However, Rogaine applied after a transplant starting on the 3rd week to maybe the 3rd month can also help accelerate the regrowth of the transplanted hairs in our experience. One way to know if PRP is working, I tell all my patients this, if a patient has some hair prior to doing the transplant, we do the transplanted hairs will not start regrowing for around 3 to 4 months. So if they notice prior to the transplanted hairs growing in, so in that first 2-month window, their hair feels fuller, they're having less shedding, that may be a good indication that PRP is effective for those patients. So those are the patients that can repeat it and do it every 3 months after that. Is there any way to turn the hairs of a cowlick back on the head around so they lay flat? Cowlicks are challenging, and we typically, we have to respect cowlicks, because if you don't respect them, in other words, when you're making recipient sites and the patient's got a cowlick, which is that swirl, if you ignore it, you'll actually damage the hairs in the cowlick because you're going to be transecting them potentially. You'll actually leave the patient thinner. Many times if a patient has a mild cowlick, I'll make it even more mild if they don't like cowlicks. In general, I don't like cowlicks because I prefer when hair grows forward. When you have cowlicks, the hairs in some areas grow backwards, so the density will never be as good. But can you get rid of a cowlick exclusively by doing a transplant? In general, no. Crown area, this is a nice segue into that. Crowns are always more difficult to work on than frontal areas, almost universally. Not in terms of the actual technique, but in terms of the results. I like to tell a patient, if someone comes in with a bald area this big, and it's on an egg size, and it's on the front, and then another one on the back, same size area, you put 1,000 grafts in that frontal egg size area, you're going to make them look around 60 to 70% filled in. That same size area in the crown, same number of grafts, same number of hairs, same regrowth rate, it's only going to look 25 to 30%. That's the challenge of working on the crown, and that's due to the fact that a crown is a convex surface. Crown, the hairs grow in a radial direction, as opposed to here, they all grow in the frontal direction, all grow in the same direction typically. So in general, crowns are not as good an area to work on. They're more challenging. How far down the forehead do you elevate in the hairline lung procedure? I'm only going down maybe an inch below the hairline, so we're leaving the brows undisturbed, unless a patient prefers to go ahead and also have a brow lift, in which case we can go ahead and go down and do the brow lift. That was from my buddy Dave Sherris up in Buffalo. I'm grayer on the sides than on the top. How does that figure into aesthetic treatment? Another great question. In general, hair in the back of the head is the last to turn gray. That's why we like that hair, particularly for eyebrows. However, also when doing transplants, guys, if we're harvesting more hairs from the back as opposed to the side, they're going to be a little darker. For most patients, that's not an issue. We will, though, if it is going to be more of an aesthetic challenge, we'll mix in hairs from the side and hairs from the back and mix them in so they don't have darker patches in certain areas and grayer patches in others. Another thing to consider when you're talking about back versus sides in terms of graft quality or graft type or hair types, sometimes patients have much coarser hair in the back of the head than what they have here and or some sides here. So you have to be very cautious with these patients. We need to use finer hair to create a soft hairline. So many times what we will do is take hair from the lower back of the head to use for the frontalmost hairline. Those tend to be softer. We can harvest them nicely by FUE, and those are ideal for creating a more feathered hairline. So that's another way that we can use quality of donor hairs and mixing and matching to balance what my aesthetic vision is and to create that outcome. When we're doing beard transplants, we use the hairs in the back for the goatee and this portion in. We use the side hairs for the sideburns and the posterior portion of the cheek beards. Makes sense, it's a closer match. Next question. Are you adding stromal vascular fraction to your fat? What can you expect after one treatment and when? SVR is first of all, there's a lot of debate, the value of SVR. It's a rather technical question. At this point, we are not using stromal vascular fraction. We are taking our fat, we're filtering it. It's a little more technical question, but we're filtering the fat, and then we're adding PRP to it, and then we're injecting it. And that's how we're using fat. How do you approximate the number of grafts to use while examining patients? Any rules of thumb you use? They talk about ideal densities. You want to create a minimum of 25 to as many 45 follicular units. Each follicular unit has on average 2 hairs. You want 50 to around 80 hairs per square centimeter to get a nice look. So you can map out the size centimeter area you want to fill, and then you can go ahead and determine how many grafts you need, how many hairs, and therefore how many grafts. I've been doing this for 25 plus years. It's almost a gestalt. I shoot from the hip, or it's not even a shoot from the hip. I know from my heart that how many hairs approximately are needed. I estimate, so for example, a patient comes in, has a certain amount of area of hair loss. I look at the donor hair, how thick it is. I'm able to assess all those things, factor that in, say, okay, you need a procedure of 22 to 2,400 grafts. Obviously, in certain patients who have a rather more advanced degree of hair loss, who are looking for optimum coverage, I'm going to go for as many grafts as possible, which typically the upper end is around 2,700, 2,800 that we can obtain in one procedure from the scalp, usually over a day and a half. Usually anything over 22 to 2,400 grafts requires a second day. The way we do these procedures is we harvest the hairs from the back. We typically get 1,200 to 1,600 or 1,800 grafts from the back. We'll start the planting process around 2 hours later after these have been harvested. Later on in the day, as we need more hairs, we'll start taking them from the side. This way, hairs that we're transplanting, for example, at 3 o'clock in the afternoon, were not hairs that were harvested at 8 o'clock in the morning. They were harvested at 1 p.m. So they're nice and fresh. So those are some of the rules of thumb. I thought hair cloning was abandoned. Well, hair cloning is yes, that's a great point. Some Adirons bought a hair transplant company in the hopes of launching hair cloning. They spent hundreds, or my understanding, tens of millions of dollars, were unsuccessful with their efforts. This new effort that I'm involved with Hair Clone is a much more smaller startup type organization. It's got the involvement of some of the top colleagues. We're all hoping that the eventual technology, which have been developed over the span of the last 15 years, will find a role for treating, particularly letting patients bank their hairs and being able to allow those hairs to then go ahead and allow them to rejuvenate existing hairs, not necessarily regrown hairs. 3D printing is something that is also being under investigation. Basically, the concept is actually being able to take follicles, multiply them, and then in a template, be able to generate new hairs one at a time. That's not what that's not the typical use of hair cloning. Typical when we think scientists or doctors, we think of hair cloning. Sorry, my Siri went off. We typically think of hair cloning as multiplying certain cells and then injecting it into the. I'm so sorry. Bad girl, sir. But then there's hair cloning. What we're using this is for, but this is with 3D printing, hair clones generating a large number of hairs using 3D printing. That's all under investigation. Does sandalwood or artificial sandalwood work? In general, if anything really worked well, other than laser, Rogaine, Propecia, and PRP, and maybe vitamins, particularly in women, you would know about it. So all these advertisements where these vitamins grow hair, really, if anything really cured hair loss, do you think they would even need to advertise? It would be spread around like wildfire, and everyone would be using it that's suffering from hair. Sandalwood or certain products can make a hair look fuller, can make a scalp healthier, therefore get better hair growth or make it look fuller, but it's not in and of itself a cure or treatment. Have you had issues with transplants on diabetics? In general, we're talking about type 1 diabetes or insulin dependent. Type 2, no, that really doesn't seem to be an issue. My only observation with type 1 diabetics, those that take insulin dependent, and that take insulins or insulin dependent, is that there may be a little bit prolonged numbness of the scalp. Most patients regrow sensation very quickly if they lose it at all, because the recipient sites are so small. But I've had a couple of patients with that have insulin dependent that have reported that their scalps were a little numb, both in the donor and the recipient area. It comes back, but that's something that just needs to be considered. I was Norwood 3. I had one hair transplant about 1.5 years ago. The hair density along the hairline does not look dense. Is that normal? I heard the best transplant density is about 40% of native hair. How much improvement is there if I have another hair transplant? Is it normal to have 2 hair transplants? For Norwood Class 3, typically if you're creating a reasonably conservative hairline, Norwood Class 3, I would anticipate using around 2,000 to 2,200 grafts, placed into a relatively small area around like that. Spread out the hairs over a wider area, of course, is going to be a compromise in density. So it's hard to say in this case how many grafts were done, how widely they were distributed. Does it not look dense? Well, I mean, that needs to be discussed with the surgeon ahead of time, what your goals are. Many times I'll do a softer hairline. I talked about feathering the hairline and making it denser. Other times patients want a more dense hairline, and I'll talk with them. The patient needs to understand the pros and cons and the realities of that. I've heard the best hair transplant density is about 40% of native hair. That's not true. Typically, you want to get at least 50% of the native density to have the appearance of a relatively full head of hair. So if you're falling short of 50%, even when you're angling the hairs forward, that generally will look a little bit thinner. There are other issues that come into play when we talk about density. Of course, thickness of the individual hairs, how many hairs were transplanted. Also, very importantly, the color contrast between the scalp and the hairs. So for example, dark scalp, gray hair, best result. Dark hair, very dark, thin hair, very fine, very light scalp, much more difficult to achieve density because you're always going to see scalp shining through. So that's another issue that needs to be explained to patients. How much improvement to continue? How much improvement is there if I have another hair transplant? I love doing second hair transplant procedures, particularly on those patients that are coming with not a lot of hair, because I explained to them with the first procedure, I can achieve around 35, 40% the original density, still look a lot better. Then when we come back and do that second procedure and I fill in between the existing hairs, I can essentially double the appearance of density, if not even more than that, which is really impressive. Next question. Originally had 2 FUT transplants, and now I need to fill in the temples and crown areas where I've had more hair loss. Do I need to continue with FUE transplant, or can I have FUE and fill in my scar? The answer is both. Sometimes if the patient has a relatively loose scalp and they already have a prior FUT scar, we'll go back, remove the old scar. Then we can do FUE. So if you've not had any FUE done, most of the grafts are going to come now by FUE, because we can harvest the entire lower back. We can harvest the sides. Sometimes we can even harvest above where the scar was made. So particularly patients that have had a prior strip scar, I will many times do if they want to, I'll do another second strip, removing the old scar. Or if they're at all hesitant, I will go ahead and just do all FUE. And with FUE, we can harvest hairs from areas that we were unable to harvest hairs from originally with the strip procedure. My patients that have had prior FUT procedures now get FUE are blown away by how much easier of a recovery it is. FUE, basically that first night, most patients don't even take pain pills. The procedure itself is painless, whether it's FUE or FUT, but the recovery is a little easier with FUE. This typically doesn't hurt at the donor area. If you do a strip for the first 2-3 days, can hurt. Plus it's more invasive, it's tight. With FUE, you just don't have that issue. Is it possible to have FUE grafts in temporal areas? Yes, actually FUE grafts, but you only want to use single hairs in the temples because you want them to lay nice and look natural. Temples are the more challenging areas of the scalp to transplant. Should only be done by a real experienced surgeon, and the grafts need to be laid really nicely. And typically, if we will need to take 2 hair grafts that occur naturally from the back and divide them in half. Next question. Does topical I'm spacing. I'm sorry. Does the eyelash lattice, does lattice work? Or does topical finasteride work? With lattice, lattice is primarily used for eyelashes. It can help eyelashes grow fuller. There have been some patients of mine that have tried lattice. It's expensive, but they try using it. It's Umatoprost. They try using it on the scalp. My experience has not been, at least with my patients, have not really seen an impressive regrowth. Topical finasteride is something because patients are concerned about taking oral finasteride with its risk of reduction in libido. Topical finasteride applied either with Rogaine or in itself may have some efficacy. Haven't been enough studies, but some doctors are starting to report good results. Interestingly, oral minoxidil, going old school, because that was the original indication for minoxidil was as a blood pressure lowering medicine. Given orally, it can lower blood pressure, but it also can cause scalp hair growth. So there's been some renewed interest. What hairs do you use for persons who have widow peaks that have thinned and your center is off because of the thinness? Do you round it off or add more hair to fill out the point? Depends on the patient. Widow peaks can be created. They're very delicate, need to be finely done, but it can give a really nice look and can provide, as I said earlier, create a lower appearance of a hairline. But they use all single hairs typically. How do you approach procedures on patients with diffuse thinning? Are they good transplant patients? I actually had a patient that came to me, a diffuse thinning. It's called diffuse unpatterned alopecia. And he had a little bit better density in the back, but not a lot. He had diffuse thinning here. In his case, I gave him conservative expectations. I was able to harvest around 1,200 grafts from the back of his head throughout the entire scalp, place them right in a small area, and help frame his frontal forelock, and it made a significant improvement on it. However, most patients with diffuse alopecia are not good candidates for transplants because their donor hair is just not thick enough and it just doesn't give a nice enough result unless they have a very small area that they wish to have filled up. Do you use ATP for grafts? ATP, adenosine triphosphate is those of you that were took biology classes, ATP is part of the energy cycle. We use ATP in our storage solution for the grafts. So we, at the beginning of a case, we put chilled, not saline, but something called plasmolite. We mix ATP. It's commercially available. It provides energy for the hair follicles. It helps them to stay alive and stronger. So basically makes them stronger, so they're less likely to die. So therefore, our regrowth rate tends to be extremely high, at least 90–95%. We also give to all of our patients after a transplant, we give them a bottle that contains ATP that they spray on their scalp for the first 3 days to help with healing. Is hair transplants good for women? To summarize, in general, yes, but the right woman. And we're going to be having a webinar on that as well. Benefit of microneedling versus not with PRP. Result in microneedling as a solo treatment. Another great question. Microneedling in and of itself, which consists of making tiny little, like using a roller or some other way of making tiny little dots or little needle sticks in the scalp, actually has been shown to, in some patients, cause better hair growth. You couple that with PRP, you inject PRP, and then we microneedle to activate the PRP, but the microneedling in and of itself may be also initiating or helping or assisting with hair growth. So we do like microneedling, and there may be a role for it as an independent treatment. How can you successfully graft into an FUT scar? How successfully? Great question. FUT scars are thicker, like any scar. We can get regrowth. Typically, my goal with FUT scars, if a patient's got a prior strip scar, place around 300 grafts, typically can get around 50% coverage, which will give what will break it up and generally make it look moderately better. Many times we'll couple that with SMP or scalp micropigmentation. Do you see any cobblestone appearance to donor sites? Any keloids in donor or recipient sites? In all the years I've been doing hair transplants, for over 25 years, I had one patient with a donor site scar keloid. Interestingly, he wasn't even of African ethnicity. He was of Middle Eastern ethnicity. He was Syrian, Lebanese, excuse me. And I was able to treat the keloid with injections of steroids. So typically, keloids do not occur in any part of the scalp, and that includes in the eyebrows, but also in the scalp. And what was the other question there? Let me see. Do you see any cobblestone appearance in the donor site? No, but you can see little dots where the hairs are missing. There should be no cobblestoning here. Patients can shave their scalps. They should have no problems going ahead and looking totally natural, even when their his hair's cut short, even when someone looks closely in a really well done transplant. What's your best guess for a hair clone being commercially available for treating hair loss? Well, probably in the next 2–3 months. We actually had a delay. We were getting ready to start harvesting hairs, starting to bank hairs and sending, we got approval for that. This is obviously going to set things back 6 months. We're probably looking at resuming harvesting the hair clone hairs probably in the next couple of months. Then we anticipate the ability to multiply the follicles will be available within the next 2 years. And then finally being able to safely inject it into a patient's scalp may be another several years as well. However, the reason why we're starting to harvest hairs now is the younger the hairs are when they're harvested, better the DNA and the stronger they'll be. Next question. What is your advice for someone with a scar in the pubic area with an implant 2 millimeters below scar? I actually was going to show a pubic hair transplant. I've done these. I probably have done around 6 or 7 for patients that have had prior penile implants or penile elongation surgery, typically, or transgender patients, female to male. It leaves a scar. You can fill it in beautifully, single transplant procedure. There should be no issues. The scar would be gone. Oh, thank you. I want you to do my hair transplant. And thank you for a great educative seminar. Risk of damaging the implant, I assume you mean with the transplants, nowhere near there, so it's fine. You don't have to worry about a penile implant being damaged or a chin implant being damaged by transplants to the chin or pubic area. Dr. Epstein, will ATP spray alone work to help hair grow as well as using PRP? Probably not. ATP doesn't seem to have any advantages of itself. So, last chance for questions. I wanted to end at 5:15. I so thank you all. If there's any more questions pop up, I will answer them. But in the meantime, I want to thank everyone. You've been a wonderfully quiet audience. Of course, I've been muted, everyone. But really, if you have any other questions, please feel free to email us. I have Roxy and Danette, my 2 patient advisors, where they're working every day, like regular. We're doing webcams. I'm doing several of them every day. Also able to do photo reviews, but really I'm here to answer questions. It'd be a pleasure to have you participate in other webcams. I enjoy sharing this information. I hope you realize the reason I'm working hard is not just because I want to take care of my patients, but also I really want to get my practice back going, because I've got a lot of people here in the office that love what they do, but also rely on income for the practice. So that's why we're continuing to work away. Some people may say, well, why are you talking about hair in the middle of a pandemic? But this is what I do best, and it's my way of contributing and helping everyone feel better about themselves that are bothered by their hair loss. So anyway, once again, thank you. Feel free to email us, visit our website, foundhair.com, or www.drjeffreyepstein.com. You can email me through there. Everyone stay safe. Thank you and goodbye. Have a good evening.